All right, we are back with another PCBH Corner, and for the second time, Dr. Bob Phillips is going to be joining with us today to talk a little bit more about primary care and particularly high quality primary care. And we already had Bob on, and I'm really grateful for him making a second appearance for this. And the one thing that I'm going to put in the link description of the video, or the description of the video, is the link to this incredible report called Implementing High Quality Primary Care. And it's a long report, and Bob and his team have done a great job also breaking it up into chunks. And there's like overviews and summaries. I would recommend definitely reading the entire report, as we have our interns and fellows do at our at Community Health of Central Washington. And definitely, if there's not time to do that, there's a lot of great snippets and summaries of different things. So, Bob, the one thing that I wanted to start out with, we're approaching kind of an interesting point where, we're about 4 to 5 years post the report, which my mind predicts, I'm sure the report was taking a lot longer before it came out to go. Any revelations that you have seen since the report has come out? Any kind of outcomes that you want to discuss? Any things, new visions, rethinking things, even from the report, building off the report? Where does your mind go there?
Well, David, I thank you for this opportunity and Happy New Year, by the way, at the beginning of 2025. Not just the turn of a year, but the turn of an administration and a need to rethink how we strategically advocate for this report and for what it seeks to achieve. And thanks too for pointing out that on the website for the report, there are 2-page briefs for every single one of the objectives. So it really is broken down into digestible ways to enter the report.
Read the entire report.
Yes, read.
And if you can,
There's a lot of rich content in the report. That is absolutely for sure. The report really focused on 5 key objectives, and if you think of them like Maslow's hierarchy, that some are necessary to achieve the next levels of success. The first objective was about payment, and because until we pay for primary care differently, you can't achieve the other ones. You can't achieve the ones about workforce. You can't achieve those about access. You can't achieve those about improving health information technology. And so I wanted to start there because there's been a lot happening around payment. Federally, CMS really embraced this report, saying publicly that they used it as a blueprint for their new payment models. And that includes a 15-state demonstration model called Making Care Primary, another 6-state demonstration called Ahead. Making Care Primary focuses on agreements with practices, with all payers, really collaborating on paying for primary care differently and moving people from fee-for-service all the way to capitation over a 11-year period. And Ahead is agreements with states to organize how they pay differently and to build out infrastructure to help primary care succeed. Also a 10-year, decade-long runway for moving practices from fee-for-service to capitation, which was a major emphasis of the report. And then CMS broadly last summer exercised an authority it never has before by declaring a new advanced primary care management fee, which is a per member, per month capitated fee, not dependent on visits, to have a graduated scale of payment based on the complexity of the patient. So it's designed to give practices a known upfront quantity of money to help them manage complex care and to build out the teams that they need to do that. So I think those are the major kind of payment things that we've seen the report help stoke. There was also a major report out of Oregon that AHRQ, the Agency for Healthcare Research and Quality, funded, trying to assess the landscape of the states that are moving towards a minimum primary care spend. So these are state efforts to get at payment, a very blunt policy, but California, for example, this year said that they were moving from about 4% of total healthcare spend on primary care to 15% as a goal.
Whoa.
That report, what it revealed is that the data sources that states are relying on often force them to use proxies. They don't know where their primary care physicians are. They don't know how many they have or clinicians. And if you don't know who is working in primary care and where they're located, it's awfully hard to say how much is being spent on primary care. And so this proxy war of, well, is it based on conditions? Is it based on settings of care? Is it based on a number of diagnoses means that it's been a little chaotic and schizophrenic across the country, and it's hard to compare Oregon to California
Mm.
in terms of the way they defined primary care. So that report I think was important, and it was ARC's. It was one of AHRQ's investments in this report. Um, is likely to lead to AHRQ putting out a funding announcement this year about developing that database. How do we create a resource for the country so that states can understand and better direct resources to primary care, and so feds can better understand, how do we prioritize our workforce needs? How do we prioritize access points? Because now we have a better lens on what primary care is really doing. And to their credit, ARC actually used some proprietary data to put out a report about that earlier, last May, in fact, showing that we vastly overestimate the primary care clinician workforce. It's probably 50% lower than we estimated.
Wow. Wow.
Um, Below 200,000 clinicians, not physicians, clinicians working directly in primary care across the country, the lowest point it's ever been. So the data, there's a push for the data needs to understand the population, access to primary care, and the primary care capacity for further investment has been a big win in the last 6 months.
Okay, can I ask you a couple different things my mind
Yeah,
is going
yeah.
to in this, follow-up questions. The one is, and I don't, I think it will be a make sense of a question. Working in a community health center that I work in, and talking to a lot of colleagues, whether it be it really is transcendent, whether it be behavioral health providers or medical providers, and particularly as you get into like leadership, talking about finances and talking about like all these different things. It almost seems like, oh, it's so out there into and then it becomes a very kind of a barrier within even just day to day aspects. Is there any advice? Any tips or strategies or different perspective shifts to give to people that might be on the boots on the ground, might even be in leadership positions, but still kind of away, kind of a couple of degree separations away from like kind of these larger things that just allow people to lean into this conversation of finances and reimbursement? Like anything that you have seen that's been helpful of like embracing the reality, like we need to talk about this, we need to advocate, we need to look at the financial structures a little bit more.
No, absolutely. There's a group of philanthropies that have come together to support another project, David, that does something we said that this report needed, that we needed, and that is what is the model we want to achieve?
Hmm.
Who are the clinicians? Who are the staff support? What are the relationships in the community we want? What does that look like? And then what does that cost? So, rather than focusing on like California moving to 15% of total spend in primary care, how do we actually dedicate the funding we need to develop the model we want? And I
Hmm.
think that's been a critical issue.
Hmm.
The relationship between the model and the financing is intrinsic. I mean, it is just so critical. So you can't avoid the conversation about the financing. It has become so toxic, David, that financing has forced people to push primary care to not being fundamental and foundational, but being basic. How can we just get people in the door, get them triaged and on to the next set of services? Now, I know that's not true of community health centers. You have a model.
Hmm.
But how do we keep that vision of
Hmm.
how do we really want to take care of this population? What is the staff and the functions needed to do that? What does it
Hmm.
cost? And how do we ensure that we're getting paid sufficient to make that happen? That's the fundamental thing for us. And I know the conversations are hard, but if we don't keep those conversations going, people lose sight of what we're trying to achieve and just operate to what the financial realities are. And we're not going to advance that if we can't think bigger.
But I love how you said that about like really starting, with the end in mind about what type of like model, what type of care we want to provide. And this is what my mind heard. Let me know if this isn't what you were saying. Primary care turning into this almost like triage and refer kind of thing. It's like that doesn't embrace this idea of high quality primary care, which, as you said, is like being reflective of the community's needs, that's comprehensive care, that's relationship based. This a triage and refer, and we always talk about this from a behavioral health standpoint, standpoint, because that's oftentimes what, when you look at behavioral health providers getting integrated within primary care, they just turn into triage and refer, right? They just get them to specialty care, and no one likes that, and no one goes, and it's not good for the community, it's not good for the relationship. And I love even thinking about that broadly, about primary care not turning into that it's just a triage and refer.
Well, right. No, when it's focused as a triage and refer, then you don't need a very sophisticated workforce to achieve that, right?
Yes.
And so it solves two problems. It means that we can it creates an easy button for politicians. We just want to solve the access problem. We're not specific about what access to, to what we want people to access, but we need an easy button. So we're going to dumb this down. And when I say that, I don't mean any particular workforce or clinicians, but the function. If we just make sure that people can get in to see someone, we're going to declare that a win. And that's a problem. It's also a
Mm.
problem when health systems are consuming primary care. Their goal is to get bodies into beds and into surgical suites and to procedures. And so it reinforces their interest of, just get anyone in to anyone at any time, is the priority. And so you see health systems around the country where they're actually creating measures like number of new patients per month,
Mm.
which, it feeds the beast, but it doesn't take care of the people. And it shreds relationships. And so we're really pushing back with getting continuity in as a measure. California has taken continuity up now as a measure across all of its ACA insurance plans. How do we ensure that primary care is relationship based, and because that brings in trust, that brings in ability to manage complexity, it creates accountabilities that are natural, not just by demand. Um, and if we can't push back against that easy button access issue and triage function of primary care, we're done. I mean, the workforce will leave.
And again, largely my view is shaped by y'all's report and the excitement behind. I was just talking to our family medicine residents and a didactic recently, and I also just serendipitously I'm reading a new book. Well, it was uh, put out 2 or 3 years ago, a new MI book for healthcare professionals, right? And it's amazing when you start to break down how much like primary care providers really do become like superheroes when they embrace, as you said, like this relationship of continuity, of engagement with patients. And especially when you think about all the things that are just, crushing our communities, like primary care providers, they really do become the superheroes within the community if that's embraced, rather than, I really like how you're kind of just juxtaposing that, rather than it being something that is just like, hey, get people in. We don't care about the relationship. We don't care about continuity. That isn't a superhero thing. But if we do embrace that, primary care providers really do become superheroes for the communities.
Yeah, and I think Norway, a recent study from Norway showed this the best. So we have on our website, we have a compendium of all of the studies done about continuity and its impact on health and outcomes and communities. And there's a lot. But Norway's study showed that there's actually a dose-dependent relationship between continuity and early mortality. There's a
Oh.
dose-dependent relationship between continuity and hospitalizations and ER visits. Um, People who've had more than 15 years of continuity, which is very rare in the United States, have almost 25% reduction in mortality compared to their peers. So continuity is therapeutic. It is more therapeutic than statins when you look at the dose dependency. So that superhero effect is about the relationship and its value in longitudinally making sure that patients are moving towards better health. And I'm going to stick with your hero theme for a minute because 10 years ago, we convinced the National Academy of Engineering and what was then the Institute of Medicine, now the National Academy of Medicine, to work together. And it was really designed to bring the engineering perspective of how do you do things more efficiently and effectively. What the engineers turned around and told us is, wow, this is broken. Healthcare is really dependent on its clinicians to be heroes, to do heroic efforts to salvage patients from the system, and they are not given the resources they need to do
Mm.
that. And
Mm.
David, that has become a source of burnout, being relied upon to do the heroic and right thing for patients, often against the incentives in the system.
Ooh.
Um, the accumulation of that requirement has turned into burnout, and it's why I think clinicians are leaving primary care.
ask you this is a question that my mind was coming to, and now it's even more highlighted. So I'm going to ask it now. You know, 4 years ago when the report came out, compared to how you feel now, do you feel more confident about primary care? Do you feel like it's in a better position? Like how would and I don't know if that's an okay question to ask you or not, but what's your overall gestalt about just primary care?
Yeah. Um, I grew up part of my life in Hawaii, and there's when you're body surfing or surfing, there's a point in the wave where you know it's going to break and that you've caught it.
Hmm.
It's so there's a pullback, you feel it build, feel it, feel it, build, feel it, build, and then you know right there, am I going to miss this or am I going to catch it? And then you have to lean in to catch it. And that's where I feel like we're at an inflection point. There has been so much good happening in the environment because of the report, as with the report as a stimulant. We're at an inflection point where I think things could tip. And that's why
Hmm.
I'm both concerned and enthusiastic about this change of administration. Nothing about the politics, but just about a refocus opportunity, a disruptive opportunity. The language coming out of the folks who've been nominated suggests that they see value in prevention and population health. And we need to help them understand why primary care is a solution. I think a lot of the good that was done in this last administration has built to that point that if we can just tip it, uh, there could be a lot of good things happen for not just primary care, but for population health.
We were talking about this a little bit before we started recording, and I forget the exact wording that you said. What my mind heard was like, hey, just understanding the language that's being used now and being, intentional about shaping conversation. So you said a couple of different things. Obviously, preventative care to see, it seems like this new administration is going to be potentially focused on. What other kind of things are, looking down the road over the next 4 years, should people really be paying attention to try to intentionally shape conversations that will highlight maybe values or intentions from the new administration?
I think rural is a big focus, David.
Mm.
You know, rural has lost net workforce. It has realized a growth in age-adjusted mortality. Um, there is a lot of concern that rural has been neglected in our policy efforts, and so how we organize our policy environment towards rural, I think, will help us immensely. And I experimented this with a scholar in our center this last year. She's from a very rural area of Missouri. We focused on where are the areas that have lost general surgeon, primary care dyads, because we know a general surgeon and a primary care physician can do just about everything a population needs, including allow maternity care to happen safely. And so we looked at places that had lost that dyad compared to those who had either gained it or maintained it. And we can see a statistically significant change in mortality in the areas that lost those dyads. And we can see a loss of hospitals because they no longer had both of those functions to support the hospital financially. And we saw mortality shift. And I had her go to the Hill and I said, I want you to go talk to the Missouri delegation, which is very Republican,
Mhm.
and test what is the language that gets their attention about why this is a problem and why they should care about it. And it was rural. It was the fact that rural populations had been neglected in this sense, that there could be an opportunity for a policy window to solve it. So that's the one that I'm most focused on beyond the making America healthy again and the focus on prevention and
Prevention.
population health.
So those three right there, as you said, population health, prevention, and then a rural focus. I love that. And so again, for people that are watching this, corner and thinking about, the next 4 years and shaping advocacy and different things, knowing that those three kind of, I don't want to call them talking points because they're very important. I mean, it's good things to be focused on, but knowing that those are going to be the highlights and potentially provide a synergy with where the administration's going.
No, that's right. That's right. And I think there's a good buffer here, and that there are a collection of half a dozen philanthropies that have really adopted this report as a focus of their efforts over the last 3 years. And I think that group will continue to they've made some really important upfront investments to move things from the public space or from the private space into the public space. So Millbank Memorial Fund funding the primary care scorecard allowed the HHS to announce a couple months ago at the National Academy Standing Committee on Primary Care a federal HHS dashboard on primary care with 15 key elements. We've seen philanthropy make the investment in understanding what is the cost of the model that delivers the care we want. And we're hoping to transition that into, and it already has into some of the CMMI efforts. How do we transition that into payment models once we have that basic understanding of what's needed to fund that focus? So this philanthropy has been doing really important work in starting a process that they can then hand off to states or hand off to the federal government. And I think that group gives me a lot of optimism because they are doing that role so well.
Let's go. Let's go. So this kind of aligns with somewhat of the first question, kind of building off on that. Anything, and I don't know if a new report's going to be coming out in another 5 years or something like that, but if you were going to write a new report starting now, is there anything that you would change from the original report? And change might not be the right word, but evolve, or this is something that has come up more recently, we wish we would highlight it and focus on a little bit more?
You know what, yeah, David, that's a great question. One of the things that we did recommend in the report is that the Relative Update Committee, the committee of the AMA that advises CMS and Medicare on how much to pay for services and how to amplify that for certain specialties based on work intensity and time, it's broken. We've known it's been broken for a couple decades, and we recommended that that committee be moved back to an advisory function rather than setting policy. I probably, it's a political issue, and I probably would have leaned in on that harder. It has gotten really interesting traction. The federal government is asking, are there other data sources we should be using as an alternative to this?
Mm.
That's a conversation they've not been willing to have for 2 decades because of the politics around it. But I wish we had leaned in a little bit harder in the report on that section about the data needs to drive the policy making and decision making. But it is solving itself. People are understanding it and taking it up and focusing on it more.
Fantastic. Fantastic. What do you think? And I believe I asked you this question. And I just watched that corner. I can't remember if I'm remembering or not. What do you think training wise for people that are entered into the primary care, these sacred clinics that we get to work in? What training, what tools, what skills, whether it be PCPs, physicians, APCs, or behavioral health providers, or any provider, any staff member, where does your mind go as far as like training skills to really see the vision of implementing high quality primary care become a reality?
Well, I think the first, what we've talked about in terms of what does the model look like, how do you fund it to make sure it's done well, that's critical to training. We need to train the next generation in a model that we want operating. We need to have them understanding what is your role in this bigger model of care with smaller panels of patients, because it's different than what it is right now. We're at risk with primary care moving towards a triage function that the current trainees will not know any different.
Mm,
They won't know what relationships feel like. They won't know the value of that. So we have to fix the financing, to fix the model, to fix the
mm,
training. That's the first thing I'd say. The second is, and we emphasize this in the report, we now spend over $23 billion a year in training physicians. It goes to teaching hospitals by
mm,
and large, and there is no accountability for that funding. There's no
mm,
measurement of what are they producing, where are they doing their training. And that's something we need to fix. And that's the California Health Foundation is developing a process that I think will be valuable nationally, is looking at what are all of our teaching hospitals producing.
mm,
What primary care workforce, 3 years out from training have they produced? What general surgery, what psychiatry, what rural, what community health center workforce have they produced?
mm,
How do we just create a way of monitoring that so that we can then create accountability for it? And the reason the states are getting invested is because they're putting in over $8 billion a year in physician funding, training funding.
Mm.
So there's an intrinsic need in the states to do this. And so we're starting with California. We've worked with Florida to do some of this work. And now we're looking to do this on a federal level. And again, with the turnover administration, there's a stronger focus on accountability.
Mm, mm, mm.
Let's let's harness that and really push on how do we use these dollars to train the workforce we need where we need them and to the model that they need to deliver. That's we need to harness that $23 billion differently.
Yeah, I like that. And almost adding like a fourth kind of talking point to the population health, preventative, rural, and now accountability, right? Like, how can we show we're kind of? I like that. I like that language, and I love what you said at the beginning of that too. And it is when you take a step back and you see the potential ripple of what training within a certain kind of condition or a certain kind of context, that then it breeds expectation of that is what this should be, right? So if you're getting training in a place that's just triage and refer, that is going to ripple out to produce the following context of believing that is what it should be. And that's why I always have such gratitude of working in the Pacific Northwest, where, UW has done a great job of being like, hey, we're keeping primary care, full spectrum. We're keeping everything, and that ripples out and touches every single thing within our whammy kind of our states that we get to work with. And I think that's a really interesting point of making sure that trainees, whether it be medical students or residents, are getting that full experience and very much valuing the relationship, continuity, and comprehensive primary care.
Yeah, the American Board of Family Medicine, the parent of our center, collects very specific data about what the workforce is prepared for as they leave training and what they're doing afterwards. And we've published on this that, our training programs in family medicine are very much still focused on continuity and comprehensiveness as requirements of training. And when you ask people as they leave family medicine training, what do you plan to do and what do you feel prepared to do? It is a much wider scope of practice than they wind up doing.
Hmm.
They lose functionally about half of their capacity because the models of care out there don't support it. And
Hmm.
so there's been this tug of war of, well, should we model our training more to the environment that our graduates are going into, or do we continue to train to the model that we expect primary care to deliver and work on getting the environment to shift? And so, the ABFM has really pushed back on any efforts to constrain the content of training to conform to the environment. And that's why the center's work is focused on how do we shift the
Hmm.
environment. And that's why this report is really focused on that. So we are going to lose the battle if we lose it in training. And that's why I think training, particularly for nurse practitioners and PAs and general internists, needs to continue to focus on what is the model of care that we want and how do we train and prepare the workforce for that.
Well, that got me hyped. That got me hyped. Let's go. Wrapping up, as we come to a little bit here, we asked this question. I'm really curious about what your mind's answer is going to be, and even if it's like evolved, I'm sure over your career. The one question we ask our residents, I guess I'm giving a question away for our applicants. We're still in interview season, but that's okay. Is what brings you joy in medicine? And I almost want to like shift that for you. Like, what brings you joy in primary care? Like, is there any kind of value or any, we talked about it, I'm sure some of these factors, but yeah, what brings you joy in medicine? What brings you joy in primary care? What keeps you going with this?
Well, that's a great question, David, because I still see patients a day a week,
Yeah.
and in the environment, it's a learning environment for me largely to understand, what are the practical struggles that a practice goes through on a day-to-day basis and trying to manage the population it's accountable for. But when the door closes, that's where the joy is for me. It's the relationships that
Mm,
I've established with people, the trust that they put in me, um, and how we negotiate the next step in their health journey.
mm,
What are their values? What do they want to achieve? And what are their hurdles? And how do we get it? How do we
mm,
get them past those? And that takes time. It takes time to do that. So, um,
mm.
when my patient emails me or texts me on Christmas Day saying, just celebrating 35 years of sobriety, you know, getting back on my bike today and riding another 10 miles.
Dude, I'm here with you, man. I
That's
could feel
joy.
that. Yeah, I could feel that through. And again, and you know what? I always think about this within those stories right there. Like, I wish it wasn't, and I would love to know even your perspective because my mind goes, that's a rare event to have someone have a relationship with healthcare like that. That I'm going to wake up today and I'm going to let this individual know in healthcare that, hey, I'm celebrating this today, or I got on my bike today. I always talk about that with our residents and our psychology interns and fellows. Like, whenever there's a moment of someone being excited about coming in and be like, hey, I did this, right? It's like, what the hell are we talking about? Like, how incredible is that? And
Right.
it goes, and my mind goes to, I'm sure where yours go. If we don't have relationships with our communities, the way again the report defines, like there's just a lower probability of that conversation ever happening.
There is, and there's always the risk that it gets overwhelmed by, I've got this care gap list on the bottom left-hand corner of my EHR.
Yeah, yeah.
Are we going to focus on that today, or are we going to, celebrate this person's sobriety for 35 years and talk about what makes them joyful? I never have what made the patient joyful most recently on my list. Um, so you're right that those relationships are just it's so hard to tell policymakers this when you
Yeah.
experience this, you know it's working. You know it's working. And I kept this person out of the hospital because they felt like they could text me and tell me what was going on and I could get them into more appropriate care sooner. Um, you want that kind of relationship if you want to improve outcomes and reduce costs.
And it's a both and, right? Like not only is it
Absolutely.
like an enriching, fulfilling, rewarding experience as a professional, which is going to buffer burnout, it's going to keep us going. It's cost saving, like it's good healthcare, like it's across the board. It's a transcendent thing. Can I ask you this? Because the one thing that we have struggled with, I would say, within our residency program, obviously our 3-year family medicine residency program, and then also our psychology training programs, which usually are 1 year of internship, a second year of fellowship, is it's so tough to talk about what you just described and the emotion that came up, right? Like
Yeah,
it's such an experience, and just due to the nature of training, that it's a finite amount of years and months,
right.
you don't oftentimes get those relationships. I mean, you get obviously very meaningful and connected relationships, but not ones that span over multiple years, maybe decades of working with people. Any suggestions for people that are working in these training environments of trying to talk about that, convey that about what that is like?
Yeah, I think part of it is when I work with so unfortunately our interns aren't allowed to see patients on their own because of a licensing issue.
Hmm.
And I think that's tragedy because it means we miss a year of opportunity for them to build those relationships and experience.
Man,
It is just a tragedy. So when I'm working with them, I always look at the list and I don't have new patients very often, but when we do, I'm like, this is your patient. You
ah,
know,
ooh,
you,
ooh.
you need to give them your business card. You need to tell them that you're interested in being their doctor. You need to ask them what they're most interested in achieving in their health, not just what are they concerned about today. Lean in. Don't be afraid of it.
Ooh.
Embrace it, and plan a follow up with them so that you have that second visit to really build on. Um, so in residency programs where they don't have that constraint that I have, it's man, give them business cards. Tell them to hand them out and tell patients that they're interested in being their doctor. Um, Talk to them about how you um, asynchronously communicate with those folks. You don't have to give them your cell phone number out of the gate, but there are patients you'll want to do that because that will be the most effective way to take care of them. But have them talk, have them learn how to respond to people asynchronously in a way that shows I care about you.
Oh,
Not just
brilliant.
I care for you, but I care about you. And as soon as that's my greatest concern of moving to an AI assisted inbox.
Some AI questions. I'm glad you brought it up. Yeah, where's your mind go? Yeah.
I think that AI is more empathetic, but it means the patient isn't really building the relationship with the physician or the clinician. And that's what's going to get lost in that. And so they're going to have to find ways to have those asynchronous conversations and not rely on AI or a nurse or someone else to triage that message. Um, because that's where the relationship gets built, and that's how they'll by their third year hopefully have at least 10 or 12 patients with whom they have that kind of relationship and know what to look for.
and know that this is, going to be, staying in primary care. It's going to be amplified in the career. It's going to grow those 10 to 12. That's exponentially going to grow as you get into your career. And I love how you said, you kept using that word, and I love how you said it when you said about giving the business card, that I'm interested and almost like excited to be your primary care provider. Like that in and of itself can be a powerful thing.
Yeah, I mean, Peabody said it over 100 years ago, though, the secret of caring for the patient is in caring for the patient. It's it's you and I think there's always a first in the first and second, even third visit, there's a tentativeness about, how much am I going to reveal of myself to you? How much am I going to engage you? And that's bi-directional. And I think the faster the physician can break through that, the more readily the patient will too. And that's the speed of trust, right? It's how do you speed up trust, because trust is therapeutic.
Damn right, damn right. That's, from the compassionomics research, undoubtedly like leaning in rather than leading out, like that produces not only better relationship, that buffers burnout. Like there's so many different things that leaning into those relationships can really just be healing across the board and for our communities. And again, I love that you kept saying, about, person. And I love in the report that it's person centered, not focusing on patient centered. Like this is the whole person. It just, I don't know, gets me hyper. Bob, any last things that you wanted to comment on? I can't express my gratitude for that. I have clinic the rest of the day, so
Yeah,
I'm
yeah.
like stoked for clinic right now. So I want to express my gratitude for this conversation rippling out into my clinic. But anything else you wanted to end with? Any other final thoughts?
No, David, I'm grateful to you for doing this. I know particularly as you're heading into a busy clinic day, so it's early in the morning for you there. I appreciate your having the conversation and taking the real time to do it. I think the last thing I would say is about behavioral health. I cannot have we really push to see this report linked to the White House Behavioral Health Initiative. I don't want that behavioral health initiative just tied to that White House. I really want
Hmm.
that value to persist politically, and then I want that value to persist as recognizing this is part of primary care, and we need to integrate those more effectively. And so that's why I'm also grateful to the behavioral health community for embracing this report and seeing it as an opportunity to move their agenda. And I just hope we can keep doing it.
And to just let my wife, who's also a psychologist, we consult around to help places integrate behavioral health, and we use the report as a mainstay, as a thing. Like if you haven't read this, go read this. And truly, when we're talking about it, is that when you're integrating as a behavioral health provider into primary care, this is your new identity. Like it's no longer a behavioral health provider. It is, you are in this system that is providing care to this community that is defined through this vision of high quality primary care. That is your mission and purpose. And I can't overstate, again, my gratitude, because it provides such a grounding view. For we've heard this from the people that we've consulted with and providers and the trainer when we do trainings, about how that view not only is inspiring, it grounds them. It's like, this is my purpose, this is what I'm striving for. And it's a, again, can't overstate how grateful we are for that report.
Well, I think that grounding and that purpose embracing is the antidote to burnout. So I'm
Oh
hearing
yeah.
it from you gives me joy, gives me hope.
Yeah, let's go. Let's go. Well, as always, for people, reach out with comments, questions, thoughts, where people's minds go. Definitely check out the report again. I'm going to put the link into the description. Yeah, Bob, anything that you were going to say?
And just pay attention to the National Academy's Steering Committee on Primary Care. That is really a focal point of continuing the conversations with feds, with states, with philanthropy, and moving the agenda. So folks listening should really look at for that standing committee webpage. It's on the NASM website. That will keep them updated on what is happening as fruits of the report.
Boom. And I'll put that link in as well. So my gratitude for today. And Bob, hope the year progresses. And yeah, let's keep focusing on primary care.
Have a great day in clinic, David. Thank you.
All right. Thank you.